Good morning, good afternoon, good evening. Welcome to this week's ICAP Grand Rounds. We're going to give everybody just another minute or two to join, and then we will get started. So please wait with us. Thank you. Okay, hello again. We have a very full program, so I think we'll get started. I'm Dr. Jessica Justman, the Senior Technical Director at ICAP at Columbia, and I'm very pleased to welcome everybody to our ICAP Grand Rounds. Um, we are going to be talking about global health security, and we're going to have four lightning rapid fire presentations, and then that will be followed by Q&A. Just as we do with all of our webinars, I'll just remind you all that for questions that you may have for the panelists, please use the Q&A box rather than the chat box. Um, and the webinar recording and the slides will be posted at the ICAP website sometime later today or tomorrow. And I'm going to begin our webinar by just providing a few framing remarks. So let's go ahead and we'll get started with that, and then I will be introducing each presenter. Okay. So let me take 2 minutes and just think about where we are with global security in the crosshairs. Next slide. So I wanted to just remind us all very briefly and at a very high level of the history of global health security because the roots are very deep and go very far back. There are mentions in the Bible and the Old Testament about how to handle leprosy. The ancient Greeks, particularly Hippocrates, yes, sorry, had a whole theory about miasmas. And in the Byzantine Empire, under Justinian, there were regulations, if you will, on how to handle the bubonic plague. I think the next part of the history that particularly want us to think about is Venice in the 14th and 15th century that developed rules around quarantine. Probably everybody in this audience knows the roots of that word centers around the word 40 for 40 days. And over time, these quarantine rules became increasingly standardized and really are the roots for our international health regulations. Um, in the mid 20th century, the World Health Organization was established, and part of its mission was to oversee these international health regulations, which certainly had expanded beyond simply thinking about quarantining of ships. And much more recently, outbreaks that probably most of us recall have played a major role in reframing the international health regulations as in the concept of as a concept of global health security. So the SARS outbreak in 2002, the Ebola outbreak in West Africa 10 years later in 2014, and then the pandemic, the SARS-CoV-2 pandemic from 2020, 2021, all played major roles in reframing our international health regulations. Um, and then that has led to an all hazards framework for global health security, where there's a wider scope and there really is emphasis placed not just on public health, but on recognizing the importance of human rights and commerce. Today, we're not going to be talking so much about the human rights or the commerce aspects. We will be focusing on the public health aspects. And lastly, just in thinking about where global health security started and where we are now, I wanted to just mention two systematic reviews that quantified the number of global infectious disease outbreaks reported to the World Health Organization between 1996 and 2023, where there were just over 3,000 infectious disease outbreaks. And then another review that uh, found that there was an average of 102 public health events per year in the WHO Africa region for the 21-year period between 2001 and 2022. So, next slide. Where are we now? I think global health security is really facing a convergence of threats. There is a weaker public health infrastructure in many countries and more difficulty with coordination. There's pandemic vulnerability. Despite having been through the SARS-CoV-2 pandemic, most countries remain unprepared, according to the 2021 GHS metric. And that all hazard strategy that I mentioned before, that widening of the scope means that in addition to antimicrobial resistance and climate change and zoonotic diseases, global health security also includes cyber and artificial intelligence threats and the impact of wars and conflicts. Next slide. And even right now, in the news, we see global health security in action with the current hantavirus outbreak involving this cruise ship that probably many of you have been reading about in the news. And interesting to see that there has been very active coordination by the World Health Organization, including with the United States. So this is a subject that is not going to go away. Next slide. Our first talk today by Dr. Susan Michael Strasser is going to take a look at the use of really anchoring public health response in primary health care. And she's going to be talking about the 717 framework. And I wanted to mention that it won't be in the other talks, but it really is a very core concept within global health security. This was put forward just about 5 years ago as a quantitative metric for reporting, for measuring the detection and the reporting and the response to an outbreak. And this diagram here just gives you a visual so you can understand that the goal is to detect an outbreak within 7 days, that's 7 days between the date that the outbreak first emerges and the date in which it's detected. Then to have 1 day to notify and initiate the response, and then 7 days to implement all aspects of an effective response. And I think you will agree that this is an ambitious metric, but we're going to hear about it from Susan. Next slide. The other talks we're going to hear about include a talk from our colleague Kevin and Dede on using machine learning to leverage both indicator-based surveillance and event-based surveillance to predict outbreaks in Kenya. We're then going to hear from Ken Wisgeiser about an expanding network of diagnostics and how that is being used in Latin America. And then finally, we will have our last very rapid talk, a talk by Dr. Ihor Novikov about antimicrobial resistance connected to Ukraine. So let's go ahead and get started with Susan. I'm going to introduce Susan, who is our Senior Director for Human Resources for Health Development at ICAP. She's a public health professional and pediatric nursing specialist. She has over 30 years of experience in nursing and public health. Um, she has a lot of experience in global health security in South Sudan and Sierra Leone and Zambia. She's been leading ICAP's REACH Fellowship in New York City. So she could tell us about many different things, but today she's going to tell us about some work that she led in Sierra Leone. Susan, please go ahead.
Wonderful. Thank you, Jessica, and greetings, everyone. We have almost 100 people on here, and I was checking the list and saw an old colleague, Rosanna Peeling from WHO. It's very, very nice to see you here. So I'll begin. This presentation provides a brief overview of the Epidemic Ready Primary Healthcare, or ERPHC for short, program in Sierra Leone, which was done in partnership with Resolve to Save Lives. Our work was part of a four-country pilot, including Sierra Leone, Ethiopia, Uganda, and Nigeria. ERPHC integrates surveillance, IPC, emergency response, and clinical readiness into one cohesive system using the existing primary healthcare infrastructure. Over the past decade, Sierra Leone has repeatedly faced outbreaks from pathogens such as yellow fever, cholera, measles, mpox, and Lassa fever. These outbreaks often overlap and can quickly overwhelm primary health care and expose persistent gaps in emergency readiness. Epidemic readiness cannot be reactive. It must be embedded at the facility level every day. This reality is what led to the design of the ERPHC approach. Next slide. This graphic highlights why any health security strengthening initiative needs a focus on the frontline primary healthcare system. Primary healthcare is our first line of defense. To eliminate missed opportunities for early detection, frontline staff need to be trained and mentored to identify atypical signal events of a potential outbreak. A system that is epidemic ready has the tools and resources at the front line where they are needed to quickly detect, report, and safely respond. Next slide. As shown in this graphic, epidemic-ready primary healthcare focuses on speed, safety, and surge. Speed focuses on rapid detection and decisive action, the 717 that Jessica alluded to. Safety focuses on protection of health workers and protection of patients. We know health workers are particularly vulnerable to infection, especially early in an outbreak. Surge is the ability to accommodate an influx in ill patients while also being able to maintain essential services, whether it's vaccine programs for children or maternal care services. 717 creates transparency, facilitates advocacy, and promotes accountability in speed, safety, and surge. I want to take a brief moment to further discuss surge and the last seven of the 717 complement. Once an outbreak is detected and authorities are notified, a series of early response actions need to be completed within 7 days. These early response actions include the following: initiating an outbreak. Number 2, confirming case definition and diagnostic testing. Number 3, identifying and tracing contacts. Number 4, implementing control measures. Number 5, strengthening surveillance. Number 6, engaging and communicating with communities. And lastly, coordinating with higher levels of government and partners. Next slide. ICAP's ERPHE project covered 200 facilities across 5 districts. They were strategically located based on population density, disease burden, and prior epidemic exposure. These were primarily community health centers, community health posts, and maternal child health posts. Next slide. Next slide. This slide shows the interventions that were used to strengthen and prepare primary healthcare sites as epidemic ready. They included IPC strengthening. In the first 2 years of funding from Resolve, we really focused entirely on strengthening IPC, infection prevention and control. We also focused on integrated disease surveillance and response. One practical example of that is helping each site to develop a seasonal outbreak calendar. We supported the early stages of case management. We focused on the 4 I's, helping primary sites to be able to identify, isolate, inform, and investigate, as well as initiate care. Community engagement for outbreak alerts through community-based surveillance. Our mentors provided monthly and quarterly readiness assessment support. We also conducted simulations as well as routine outbreak performance monitoring when an outbreak occurred, and on-site training and mentorship. Next slide. This slide shows the steady month-by-month improvement in surveillance, IPC, and overall health facility readiness during periods with no public health risk. These results are based on composite scores from the 27 indicator mentorship checklist, which tracked facility performance and guided continuous quality improvement. At baseline, IDSR performance was 78%, IPC 42%, and facility readiness 30%. The relatively higher baseline performance in surveillance likely reflects Sierra Leone's long-standing investment post-Ebola, the post-Ebola crisis. Noticeable improvements began around 6 months into the effort and were sustained throughout the project. All indicators achieved above 80%, although IPC performance, as you can see, remained the greatest challenge. And I can talk about that more if there's time in the Q&A. Next slide, please. During our project, a measles outbreak provided the first real-world test of the ERPH system, with 52 confirmed cases across 2 ERPHC districts. Most patients first presented at the primary healthcare level, where the facilities were able to rapidly detect the cases a median of 3 days and notify authorities within the benchmark of 1 day. All confirmed cases were isolated and most surge actions were implemented despite resource constraints. Overall, 98% of cases were detected within 7 days, 100% were reported within 24 hours, and isolation was consistently measured. Next slide. We also had the opportunity to test our capacity building through an Mpox outbreak. This provided a second real-world opportunity to test the strength and consistency of the ERPHC model. This outbreak allowed us to compare 174 lab-confirmed cases across 110 ERPHC facilities and 64 non-ERPHC facilities. ERPH facilities outperformed the non-ERPHC facilities across key indicators. Detection was significantly faster, PPE compliance was dramatically higher, and IPC awareness reached 92% compared to 30% in non-ERPHC sites. These statistically significant differences demonstrate the strength of the ERPHC model. The key lessons for building epidemic-ready primary health care. First, integration drives results when surveillance, IPC, triage, and case management are aligned. Second, targeted mentorship is more effective than one-off training. And third, infrastructure is the foundation of readiness. Even strong systems cannot function without reliable PPE supplies, functional ice areas, and adequate wash facilities. Next slide. I just want to acknowledge, in addition to Resolve to Save Lives, the National Public Health Agency of Sierra Leone, our staff that led this project, Abdul Rahim Yakubu, Oliver Aliza, students that were involved, and most importantly, the frontline health workers and facilities that took part. Thank you very much.
Great. Thank you so much, Susan. Now, our next speaker is Kelvin Ndede. And Kelvin is a strategic information advisor for ICAP in Kenya. He is trained as a statistician who has expertise in strategic information and public health surveillance systems. Um, his day-to-day work focuses on data analysis, monitoring, and reporting to support program implementation. Kelvin, please go ahead. Thank you.
All right, thank you very much. So today I will present on the use of machine learning algorithms to improve early detection and response to priority diseases. So specifically, we'll be talking about diarrheal and prediction of respiratory illnesses. Next slide. So this is the outline of my presentation. We will have a brief background just to provide some context, and then we'll walk through the eBridge development model. That's the predictive model, and then we look at the future applications of this model in public health. Next slide. Yeah, so just in brief, Kenya, like many other countries, adopted the integrated disease surveillance framework, which incorporates two surveillance systems. So we have the indicator-based surveillance, and we also have the event-based surveillance. So the two complement each other. So we have indicator-based surveillance on one hand that collects data and established indicators on priority diseases. And in Kenya, we have approximately 45 priority diseases that are routinely monitored through the indicator-based surveillance system. And this is reported through the Kenya National Health Information System. Now, on the other hand, we have the event-based surveillance system that collects unstructured information from multiple sources. We have data from the community, health facility, media reports, laboratories, and the veterinary sector. And this information in Kenya is collected using a SMS alert platform that is based on predefined signal codes that are being sent for any alert that presents a public health event. Yeah, so ICAP in Kenya supports EBS in 6 counties out of the 47, but we also support IBS through implementation of Sentinel surveillance in 12 facilities. Next slide. Yeah, so these two systems complement each other in the sense that the EBS signals, the event-based surveillance signals often precedes the indicator-based cases. So in many instances, by the time a disease is formally confirmed in indicator-based surveillance, there have already been a signal reported through EBS. So despite this theoretical relationship, the link between EBS and IBS has not been clearly established. And so we applied a machine learning model to bridge the two systems. So this formed the basis and the objective for the eBridge initiative. So the eBridge, E comes from the word event-based surveillance, and now the bridge just represents the role that the system does in linking EBS and IBS. Next slide. Yeah, so this slide summarizes the methodology that we used in developing the predictive model. So the first step was actually to map the EBS signals to the priority diseases. And you will see this in the next slide. We obtained data sets from the Ministry of Health, and then we conducted data pre-processing procedures before we performed the training and testing of 4 machine learning algorithms. And then now the pre-processed data was used to develop 2 predictive models. So we did one for diarrheal diseases, and then we also developed another model for respiratory diseases. So for the 2 models, so the outcome was actually the count of diseases, and then now we use the EBS signals as the predictors or the features in the model. And so eventually, out of the 4 algorithms that we evaluated, so we identified the best performing model as a rim tree, that is the random effects expectation and maximization tree model for predicting both diarrheal and respiratory models. And so we evaluated them using root mean square errors and the coefficient of determination matrices. So the model that was selected was integrated in a central data repository where we have both IBS and EBS data, just to enable real-time prediction of IBS diseases using EBS data that's coming in. And then finally, we were able to develop some visuals, dashboards that help us see the predictions in real time to support timely decision making. Next slide. So this is how the mapping was done. So we had to look at the EBS signals. So we support both community event-based surveillance and health facility event-based surveillance. So under community, we have 6 signals, and under health facility, we have 3 signals. So we mapped them to the priority diseases that are being reported through KHIS. So for diarrheal diseases, we are looking at typhoid, dysentery, and cholera. And then for respiratory, we're looking at pneumonia, upper respiratory tract infection, and lower respiratory tract infection. So those are the diseases that are being reported under indicator-based surveillance. And we were able to map all the signals to these diseases, apart from signal 3, which talks about a child with sudden weakness of the legs. So that's more inclined to polio. And then signal 5, any increased sickness, including abortion, deaths of animal, which was linked to zoonotic events. So we used all the signals in our model. Next slide. So as we can see, so we incorporated all the signals, but now we assess the feature importance, just trying to see how each signal contributed to the predictability of this syndrome. So for the combined diarrheal diseases, we had the first signal in community, and the first signal at the hospital, and the sixth signal that was significant predictors of combined diarrheal diseases. And then on the respiratory model, we had 4 signals that significantly predicted respiratory illnesses. Next slide. Yeah, so this is work in progress. We integrated that data in a central data repository so that we're able to visualize the predictions in real time. So that's basically what would be used by the Ministry of Health and any other audiences that would like to consume this kind of data. Next slide. Yeah, so this actually the project served as a proof of concept. So we've been able to demonstrate the linkage between event-based surveillance and indicator-based surveillance. So the next phase for us is to focus on evaluating these predictions against confirmed outbreaks, just to assess the real-world performance and utility. And in future, we could expand these predictive models beyond diarrheal and respiratory illnesses, just to predict any other priority diseases that can be mapped to EBS signals. And we could also apply these models to detect early signals of diseases that are spread across the border. Next slide. I think that should be my last. Yeah, so here's just to acknowledge the Ministry of Health that we work closely with, our donor, CDC, and the ICAP team for this work. Thank you.
Great. Thank you so much, Kelvin. Our next talk is going to be given by Dr. Ken Wickizer. Ken is the Phyllis Mailman Associate Professor of Epidemiology at the Center for Infection and Immunity, which is, like ICAP, a center at the Mailman School of Public Health. Ken is the Administrative Director of GAP, the Global Alliance for Preventing Pandemics, and he manages an expanding network of diagnosticians who are dedicated to the best technical practices and the open sharing of data. And before coming to Columbia in 2021, Ken was a professor of biochemistry and associate dean for research at West Point. Ken, please go ahead.
Yeah, thank you so much. And as the slides come up here, I just want to thank the entire ICAP team for the opportunity to share our passion here at GAP. Go ahead, next slide, please. And what GAP is really all about is technical workforce development and sharing technology that's been developed, by wealthy, highly productive labs like teams here at Columbia, but getting into the hands of people who really need it out in the field, out in national public health institutes, places where resources are constrained. And so what we do is we tend to work with teams on site in home labs across Africa, the Indo-Pacific, and Americas, even in Central Asia. Here you see in the upper right hand of this slide, our team, my lead technical instructor, Mr. Jack Collins, and myself down in Lima with the INS team there, the Instituto Nacional Sante, out part of the Ministry of Health team in Lima, teaching them what we consider to be best technical practices for pathogen identification. So taking other people's great ideas and making them cheaper, faster, more accessible, so that they can be applied in not only clinical research and surveillance, environmental and clinical surveillance, but also biosafety, biosecurity efforts as well. And so go ahead and next slide. And so what we were doing in Lima is teaching people how to take next generation sequencing based techniques and apply them appropriately in a sustainable way. And so the INS team goes out for approximately 26 days. And you see in the red circle in the upper right hand corner of Peru there in the north, this is the high Amazon outside of a town, Iquitos, and they go out for approximately 26 days. There's very little, what you would consider to be normal laboratory support. So they're collecting data, they're collecting samples at these very remote villages, hamlets, and bringing those back to central repositories like the one in Lima. And so some of the challenges, of course, are to retain integrity of these different sample types, whether they be blood products like serum or nasopharyngeal swabs. And what we teach them how to do is to interrogate these samples. So having them brought back to a central biorepository, we interrogate those using what we call pathogen-focused or clinical metagenomics. And in doing so, we cut through all the noise and the background. What we're able to do is to identify pathogens 1,000-fold easier, faster, cheaper than you would otherwise with the more kind of classical brute force techniques. So although it's not magical, it's not magic, but it is incredibly empowering for people to learn that they can do things that they thought they would have to send samples out to Boston, to New York, San Francisco, London, and elsewhere. They can do this on site now. They've got the workforce, they've got the technical capacity, they've got the instrumentation. All they needed to do is to have some the lines drawn between the dots, and then that's exactly what we've done. Next slide, please. So some of the results here, what our techniques have provided them is a great way for them to identify the leading pathogen. So in a particular sample, so if someone presents to a very small clinic in one of these hamlets, you can see here the first person presented there, they came up with dengue type 3. And so this is high resolution genomic data that you can actually serotype, based on the amount of genetic data. The next person right below that, RSV, followed by rhinovirus in a third person. So these are all known viruses. These are all known pathogens. Whether they're expected or not, it doesn't matter because we're completely agnostic. We look for all pathogens simultaneously in any kind of sample type. So whether that's a classic clinical sample, environmental sample as complex as, say, wastewater, Animal, human, it just doesn't matter. We extract all DNA, all RNA out of it and get at every single pathogen, whether that's an RNA virus, DNA virus, double strand, single strand. Again, it just doesn't matter. Next slide, please. So not only the knowns, but as well here, something that's incredibly unexpected. And so here we see a very strong signal from Venezuelan equine encephalitis virus, VEV. And this person, unfortunately, has a co-infection with a papilloma type 85. And so this is an interesting one because this is not something that's covered by a vaccine. This is a very rare version of papillomavirus, but it is correlated with a very aggressive form of cervical cancer. So this is incredibly valuable. It's not something that you would have probably engaged in a PCR or RDT based surveillance, but it's something that this person should probably know about. So not only do we have an obvious problem with a zoonotic virus like VEV, we have something here that's very personal to this person. That's going to be that's going to be intimate in terms of their individualized clinical care plan. Next slide, please. Furthermore, you have things like emerging pathogens. So again, because we identify all pathogens simultaneously, we get the knowns. Yes, we get even variants of concern. So variants of knowns, different strains, but also absolutely novel viruses. Here we have, of course, a known virus, Oropouche. It's increasing its presence across the Americas, marching its way up north. I'm showing just the L segment here, but it's a very strong signal. There's no doubt that this individual has this is infected by this. So when they presented with probable respiratory distress, now they can go back and be treated. If we turn this around, if we have a fast enough turnaround time, not only is this good for surveillance, but it's actually good for clinical care. And so we want this to be useful. We want to have many hats, whether that's the clinical hat, which I am not a clinician myself. That's why I partner with experts like the team at ICAP. I am a diagnostician, but I want my data to be useful. And so we teach people to be engaging in this work completely independently. Go ahead, next slide, please. So we're a very lean team here at GAP. The primary folks are on the left-hand side. Dr. Xiongzhou Liu developed the bioinformatical tools that allow people, non-PhD bioinformaticians, the ability to interrogate their own data and not farm it out, not get that off to San Francisco, not get that off to London and elsewhere, but actually own their own data from start to finish. Because if you're going to be completely independent, then you have to not only engage in the entire wet lab process, but you also have to own your data at the end. Dr. Samuel Yingst is a veterinarian virologist. He directs a lot of our Africa operations, but was instrumental here as a former CDC employee in helping us support the U.S. CDC. And I have to thank them tremendously for the financial support through, again, a cooperative agreement with ICAP. And then Mr. Jack Collins is my right hand. He's the lead technical instructor and is just today finishing up more research, more training actually at SERI at Stellenbosch in Cape Town, where we were engaged in work with Rwandans, Eswatini, Ethiopia, a Public Health Institute, and then teams from all across South Africa. So we're engaging in the work, sharing information, sharing tools, and hopefully inspiring people to engage in the open sharing of data. And that's what GAP is really all about. So thanks so much. Next slide, please. And I sincerely appreciate the opportunity.
Great. Thank you so much, Ken. And now we will hear our fourth talk for the session, and we will be having Q&A after that. Our fourth speaker, if we can have the slide for Dr. Ihor Novikov, is ICAP's country representative and project director in Ukraine. He's a medical doctor and humanitarian professional with more than 20 years of experience in international health programs and emergency response. And he has worked extensively across Africa, Asia, and in Ukraine and with organizations such as UNICEF and the World Health Organizations, and has a lot of experience operating in complex conflict and emergency settings. Ihor, please go ahead. Thank you.
Hello, colleagues, and please show the title slide. Yes, we shall speak about combating antimicrobial resistance in Ukraine. Next slide, please. This graphic from CDC illustrates the spread of highly resistant and virulent bacteria that have spread from Ukraine since the start of Russia's full-scale invasion in 2022 in multiple European countries and as far away as Japan. These threats do not remain confined within borders. Data show that Ukrainian war-wounded patients receiving care outside of Ukraine are infected with the same resistance patterns as those within the country. Next slide. February 24 marked the 4th anniversary of Russia's full-scale invasion in Ukraine. According to estimates, there have been at least 500,000 military casualties and over 56,000 civilian casualties since the start of the full-scale war. Beyond the battlefield, inside healthcare facilities across Ukraine, combat wounded soldiers and civilians face another killer, antimicrobial resistance, or AMR. AMR is one of the top global public health threats, responsible for over 1.27 million deaths in 2019. But inside Ukraine, the war has created conditions that amplify the emergence and spread of MDROs, multi-drug resistant organisms. Surveillance data from injured soldiers now includes Acinetobacter baumannii and pan-resistant Klebsiella pneumonia, pathogens resistant to every available antibiotic class. Since September 2022, ICAP has been combating AMR in Ukraine with funding from CDC and in close collaboration with Ukraine Center of Public Health. Our team is based in Kyiv, and much of our work is focused on regional CDCs and multi-specialty hospitals in 4 regions of Ukraine, 3 in the west and 1 in the east. While none of these hospitals are military hospitals, they all receive war-wounded patients via medical evacuation trains transporting them from conflict zones in the east. The hospitals in the West are often the 3rd or 4th stage of evacuation and can receive as many as 50 patients at a time. Next slide. The project aims to design, establish, measure, and scale a viable model of interventions to control the spread of resistant bacterial pathogens, tackling key AMR issues in the country. Much of our focus has been on improving infection prevention and control and surveillance of healthcare-associated infections. We are building diagnostic capacity at hospital, regional and national public health laboratories, and strengthening AMR detection and response. At the hospitals, we are building the capacity of leaders in multidisciplinary teams composed of clinicians, laboratorians, epidemiologists, pharmacists, and IPC specialists. We have created a community of practice among the teams through biweekly twinning calls with simultaneous translation, and we also conduct in-person training and mentorship. Next slide. This slide summarizes the key operational achievements of ICAP support in Ukraine in strengthening infection prevention, laboratory systems, and antimicrobial resistance response capacity. We implemented multiple quality improvement initiatives, including hand hygiene, environmental cleaning, contact precautions, and blood and wound specimen quality. With ICAP support, hospitals have implemented programmatic improvements and monitoring systems for hand hygiene and environmental cleaning. Recently, we launched serial colonization screening for carbapenem-resistant organisms and carbapenemase-producing organisms in ICUs and surgical wards to gain a better understanding of AMR burden and acquisition during hospitalization. ICAP strengthened bacteriological laboratory capacity through procurement of modern equipment, implementation of international quality standards, support toward ISO 15189 accreditation, and enrollment of laboratories into external quality assessment programs. With our support, these laboratories have expanded testing volume, introduced advanced pathogen identification and antimicrobial susceptibility testing, and methods and strengthening laboratory quality management. A major focus was the establishment of hospital-based multidisciplinary teams and creation of a national professional community through nearly 70 twinning calls and 27 webinars conducted together with European and US experts. Next slide. The project demonstrated measurable improvements across infection prevention and control measures. This slide shows data from ICAP's activities at hospitals. Environmental cleaning assessment scores improved more than threefold in selected hospitals. Hand hygiene compliance increased up to twofold with increased implementation of WHO's multimodal strategy, with 3 hospitals near or above the intermediate level. Next slide. We have also seen improvements in laboratories. Quality improvement initiatives contributed to improved quality of wound specimens and reduced blood culture contamination. Overall laboratory capacity improved substantially, with average scores among 6 laboratories increasing from 55% in 2022 to 92% in 2025, based on a standard CDC tool to assess AMR testing capacity. Next slide. Future activities will focus on further strengthening surveillance, laboratory systems, infection prevention, and workforce development. Planned work includes support for surgical site infection prevention and surveillance, and improving wound care management. ICAP will continue supporting the development of the national tiered laboratory network, connecting reference and regional and hospital laboratories. We are also developing a guide to scale up successful interventions, continuing CRO colonization screening, and implementing postgraduate IPC training programs together with leading medical universities of Ukraine. In summary, Ukraine's AMR landscape represents an urgent, war-driven public health emergency with global implications. Leveraging our experience tackling other public health threats, ICAP has achieved substantial progress in strengthening surveillance, improving diagnostic quality, reinforcing IPC, and standing up systems required for long-term AMR control. Next slide. Thank you.
Wonderful. Thank you, Ihor. So I am now going to hand things over to my colleague, Dr. Suzue Saito, who is the director of ICAP's Strategic Information Unit. And pertinent to today's discussion, she's also the principal investigator for a CDC-funded project on global health security that is specifically focused on surveillance, a multi-country GHS project. Suzue, thank you.
Thank you. Thank you very much for great presentations. We have a few questions in the Q&A box, and please feel free to add more. There is simultaneous translation as well, so we can, for those of you who need that, please type in the questions in your language. The first question, I'm going to hand this to Susan. I think you already answered it in the chat, but I think it'll be good for you to answer live as well. From Gavin Yami, might the panel share their thoughts on the prospects for a meaningful pandemic treaty? Negotiations are currently gridlocked, especially in the context of the hantavirus outbreak. Over to you, Susan.
And we're just going to ask our panelists to put their cameras on when they're speaking.
Yeah.
Thank you.
Sure. Thank you for that question. I think, COVID-19 and many other outbreaks have really taught us how um, challenging uh, outbreaks and emergencies are testing cooperation, testing trust in government, and testing trust in each other. And trust can quickly break down when people are scared, when there are a clear lack of resources. Leading to maldistribution. We saw that very acutely when the COVID-19 vaccine was first developed and some, hoarding of vaccine. Uh, and I think this question moves well beyond our ability as epidemiologists or medical providers. We know the science. We know what needs to be done. We know what steps to take to contain viruses. I think, from my example, ERPHC, it's very clear. If we have strong primary healthcare systems, if we have people at the front lines with the good eyes and ears to identify things quickly, we can ring fence them. Obviously, not 100% of the time, but we can do much better. And the challenges really are around investing in health systems, investing in equitable access to care, and investing in improving cooperation amongst states. And that's why I think we see the large reason we see the gridlock. But I'm sure others have opinions as well. Thank you.
Thanks, Susan. I wonder if Ken, do you have a comment, since a lot of it revolves around sample sharing and data sharing?
Yeah, of course. I mean, so the bottom line is that we're very much attuned to some of the challenges of sharing data in between, private entities as well as governments, and certainly across, international boundaries. That can be a challenge because even though the pathogens flow freely back and forth, people flow freely back and forth, and animals flow freely back and forth. Sometimes getting things across can be a huge administrative challenge. So we work with teams to try and make it cost effective so that these samples can be preserved for as long as possible, so they can be interrogated in the most effective kind of ways. So the silver bullet answer there is that it really depends on the situation, which is not that satisfying an answer, I know, but it's something that we need to customize the approach depending on the organization, depending on the region, and even depending on some of the people that we have to work with and have the privilege, frankly, of working with on those locations. I hope I'm addressing the kind of the core of the question. Over.
Thank you, Ken. This is a question for Ihor, I think, from Roseanne Peeling. Lab strengthening is critical and nice to see what was done in Ukraine. How can all these achievements be sustained, especially financially? So maybe you can talk about, your collaboration with UPHC and the Ministry of Health. Over.
Thank you for the good question. Actually, the Ministry of Health now pays great attention to this, to IPC measures, and of course we have now a hard time when the financial spending are very limited, especially for such sphere of activity like healthcare. But because of the war, because many funds goes to military, but we still have I think high hopes that it will be ended, and then the money will be invested more in healthcare. And now we have the government in 2024, they adopted a state strategy to combat in AMR, and the Ministry of Health and the Center of Public Health of Ukraine, they pay great attention for this, and they plan this. I think this will be sustainable. They understand the importance of this, and we are now working together with medical university. We start working with medical universities, which they put this all these measures for the future, for preparing specialists, for popularization of the certain professions which we have in deficit, like microbiologists, like epidemiologists. So we cannot say for sure that will be sustainable, but we believe this will be sustainable because the government understand this.
Thank you. I have a question for Calvin. Can you speak a little more on how Kenya collects event-based data or community-based surveillance data? Is it through community health workers, and how did that roll out? And what's the coverage of those sort of non-indicator-based surveillance data that's so critical for the performance of machine learning algorithms? Over.
Yeah, so event-based surveillance data comes from multiple sources. So one of the sources is actually from the community. So we have community health practitioners who send signals. So there are SMS alerts that are being sent through the system, and then they are being tracked through the EBS process. That is verification, risk assessment, response, and escalation. We also have data that's coming from the health facility, that is HED. So we have healthcare workers who are also sending signals through the same platform. But we also have other approaches. We have media reports, though we don't support media reporting. We also have data that's coming from the lab, and we also have from the veterinary services. So those are the different sources of EBS.
Thank you. I think, Jessica, we may be out of time. There are several other questions which we will answer by email. And I just want to thank all the panelists for excellent presentations and all the audience for excellent engagement. And I'll turn this back for closure to Jessica.
Great. Thank you, Suzue. Thank you, panelists, for tackling some of these questions. I know we didn't get to everything, but certainly it's been quite engaging. A reminder that the webinar recording and the slides will be posted on the ICAP website. Thank you, everybody. Take care.